Perfect. I think we'll make a start then. So I'll start us off for tonight. So hi guys, my name is Dylan. I'm part of the media team at BIMA and BISA. So as you guys know, BISA is a subdivision of BIMA, of the British Indian Medical Association. And today, as part of this British Indian Surgical Association event, we're delighted to welcome Mr. Joseph Manjaly, who is a consultant otology, auditory implant and ENT surgeon. I'm going to hand over to Mr. Manjaly in a second, but I just wanted to just give you a quick rundown of the events that we have to come. So far this year, we've had one event, one BISA event, which happened last week. Check that out. That's going to be on YouTube if you missed it. And today we're going to be talking about, or Mr. Manjaly is going to be talking about high yield ENT emergencies. And next week on the 10th, we have a portfolio session with Mr. Vinci. So be sure to attend that one. So I'll hand over now to Mr. Manjaly. Thank you so much for taking your time. And I hope you guys all enjoyed the talk today.
Great, thanks, Dylan. I'll just share my slides so you can all see that. Great, so yeah, thanks for inviting me on. And I'm going to talk about ENT emergencies, and do feel free to put questions in the chat box. I've asked the committee to interrupt with any questions or any comments as we go along. Just a bit about me. I am a ENT consultant at UCLH in central London. I specialise specifically in otology, so hearing and hearing implant disease. And yes, that's me. So I thought one of the interesting things about having a British Indian surgical association or medical association is that many of you will have a story, and many of you will have a story that perhaps has an effect on what drives you or your motivation. So I thought I would share mine. So my family history with regards to India goes back to 1981, where my dad, who is also an ENT surgeon, came to this country from Kerala. And his first night was actually, his first night in the country was in the Indian YMCA in central London. And back then you would basically have to pitch up and basically apply for taster weeks and any sort of observation type thing you could get hold of, which would give you a chance to meet people to apply for your first job. So it was a difficult path, and yeah, you know, it was difficult, I think, for people from abroad back then, but slowly he worked his way up the ladder. His career took him through Wolverhampton, Manchester, spent a lot of time in the Midlands before he ended up as a consultant ENT surgeon in Eastbourne. And here we are in front of the Hunterian statue at the Royal College of Surgeons. With me there, and so I guess that probably would have unknowingly had some influence on my interest in becoming a doctor, and later also doing ENT. So I went to Bristol University, and I did my foundation years there, and then core surgical training took me to Salisbury and Portsmouth, and I then ended up as a registrar in London. And I did my fellowship to specialise in ears and hearing surgery at Cambridge University Hospitals. And during that year in Cambridge, I sort of got the tap on the shoulder that there was a sort of fairly high-profile job coming up in London. And sure enough, that's where I was appointed back at UCLH and the Royal National ENT Hospital, which, funnily enough, is a 6-minute walk from that Indian YMCA in central London. So there you go. If you want a story of kind of coming full cycle and legacy, then there it is. So good. So I'm going to give you a rundown of some ENT emergencies. I'm going to get this video rolling, and I just want you to have a read of this question and have a think about what you think the answer is. So 30-year-old male presents to A&E with a nosebleed. He has haemophilia. He's tried holding the bridge of his nose for 20 minutes, but the bleeding has stopped. Which of these has no place in the management of nasal bleeding? I'll give you to the end of the video, and then I'll tell you what the answer is. So nosebleeds are very common, and not all of them end up like this. But I'm just going to give you a stepwise explanation of how we deal with nosebleeds. So the correct answer is C. And let me tell you why. We'll stop there. There we go. Cardiac arrest, etc., etc. So ENT's epistaxis, which is the medical term for a nosebleed, is a common ENT emergency. And of course, not everyone ends up in hospital. And somehow incorrect first aid advice is infiltrated through the population, even through the medical community. And if you ask many people, where do you hold your nose? Where do you ask your friend to hold their nose when they have a nosebleed? People will say all sorts of different things. But pinching the bony bridge won't do anything. So the correct way is to pinch the soft bit of the nose and sit in a neutral position. The third thing you can do is put ice in your mouth. So go and tell your friends that pinching the bony bit doesn't do anything. Okay. Now, PPE is very in fashion now, but it's always been important in epistaxis because any sort of cough that the patient does after a heavy nosebleed will result in your shirt being spoilt. So gowning up is really important. And we don't take long histories in ENT, but you want to get an idea of whether the bleed is coming from the left or the right side or coming through the mouth. That gives you a clue as to whether the bleed is anterior or posterior. You want to get an idea for their medical comorbidities and whether there are any factors that are contributing to the bleed. So hypertension and blood thinning medications such as warfarin and other newer anticoagulants. You also want to get an idea for if you manage to stop the bleed there and then, can you get them home? So now obviously general resuscitation applies. So although most bleeds are very innocent and short-lived, people can die from having a severe nosebleed. So you do need to respect it in the inpatient setting with an ABC approach. Suck out the clots and make sure their airway's clear, support them with oxygen if needed. And circulation is the big one. So you need to check their pulse and blood pressure and make sure you're replacing any lost fluid and get a group and save if necessary. And then there's a stepwise way to stop bleeds. So starting from very simple measures to much more extensive measures. So this is the first thing you want to do. You have to get a good view in the nose to see where the bleeding is coming from. So we use this speculum called a thudicum speculum and a headlight, get a good view. And then this spray is really important. So cophenylcaine spray, which is a mixture of lidocaine and phenylephrine, which numbs the nose and vasoconstricts to slow down bleeding and help you to have a good look with the patient comfortable. So spray the nose, good light. And then if you can see a nosebleed, if you can see a bleeding point, then you can use this, which is called a silver nitrate stick and perform silver nitrate cautery. So you can touch the vessel that's bleeding and basically chemically burn it and stop the bleeding. So that's a really good method to sort people out and get them home. If that doesn't work, then the next stage is packing. And there are two different types of anterior pack. There is the rapid rhino, which you can see in this picture here, where you insert into the nose and inflate it. And then the Miracell, which is essentially a tampon for the nose. You put it in, it soaks up the blood and tamponades the bleeding point. If the bleed's coming from further back, you need to use a urinary catheter. I'll explain that in a second. The key thing here is the direction you put the pack in. So there's a temptation to think that the nose is shaped like this and you want to stick it up that way, but that is only going to end up going in part of the way. So you want to stick the pack in 90 degrees to the face, although that sounds quite shocking. That is the best way to do it. And you need to do a firm push, confident push, and push it all the way to the back. If that doesn't work, then the next step is BIP, and BIP stands for bismuth iodoform paraffin paste. That's this yellow gungy ribbon. And we use Tilly's dressing forceps to essentially thread the pack into the nose. And that BIP has is hemostatic, so it's really good at stopping fragile vessels from bleeding. So this is obviously a rough diagram of how to pack the nose. Obviously, it's not very realistic, but the main thing here is that you want your thread to go right to the back of the nose rather than just bunch up at the front. So what happens if there's still bleeding and there's a lot of blood coming through the nose? Well, that might be that the bleed is posterior, coming from the back of the nasal cavity. And in this scenario, a Foley catheter is really useful. And what you do is you get your headlight and look into the patient's mouth, and you feed the catheter into the nose like an NG tube until you see the tip appear. Once you see the tip appear, pull back slightly and then inflate the balloon, and that will inflate the balloon in the postnasal space. You want to be looking here, because if you inflate the balloon in the oropharynx, then you're going to cause airway obstruction. So of course you calmly just deflate the balloon, pull back a bit further and inflate it again. And you can then pack the front of the nose with the aforementioned methods, and then clamp it in place. Now, you can use an umbilical clamp to provide tension on the balloon, but you want to make sure that there's some soft padding between the clamp and the opening of the nostril, so that this doesn't cause necrosis of the nostril, which it can easily be done if you're not careful. And if all that fails, then surgery is to be considered. And there are loads of different ways of stopping epistaxis surgically. It might just need a good examination under anaesthetic, but the most common procedure we do probably is a sphenopalatine artery ligation, which is done endoscopically. So you put a rigid camera in the nose and then essentially find that blood vessel where the red arrow is pointing, and either clip it or burn it. And that's really effective at stopping severe epistaxis. Good, moving on. So here's another question. So a 1-year-old child presents with a unilateral brown discharge. So ignore the picture. Imagine that it's unilateral and slightly mucky. No eye signs, hemodynamics stable. No, but you try and examine the child and don't get anywhere. What are you going to do next? Have a think. I don't know if there's any way of writing it in the comments. If there is, then stick it in the comments. Otherwise, I'll give you a minute just to think about it. Okay. So the correct answer is C, an X-ray. Let me tell you why. So when a child presents with unilateral nasal discharge, the first thing you want to be thinking about is a foreign body. I've got an 18-month-old child here that you might hear in the background, and they're always exploring whilst you're not looking and potentially sticking things where they shouldn't. And so unilateral nasal discharge in a child should make you think about a foreign body. Okay. And sometimes the history will be clear. Mum or dad will come with the child and say, we saw him put a bead up his nose, and examination might reveal that bead. But sometimes it's not that clear. And if you've ever tried to examine a child that young, it can be quite difficult. And so if you're not sure, if the history is unclear, then use imaging. Now, flexible nasendoscopy in theory is possible, but in reality, it's going to be quite difficult to do that on a child. So an X-ray will help rule out one important thing. And this reminds me of a case that I had when I was an SHO. Child, slightly older, uncooperative with examination. A&E phoned and said, can you see this child in clinic? And the question I asked is, could it be a button battery? Because if it's a button battery, then it needs to come out urgently, because a button battery in contact with a wet mucosal surface will erode and destroy everything in its wake. The mum at the time said no, but she wasn't sure. Lo and behold, the X-ray shows a button battery sitting in the nose, and you can see that double halo sign on the X-ray. So no history of button battery, examination not that clear, but some unilateral nasal discharge. That was enough to get an X-ray and identify it. And lo and behold, we got the child to theatre straight away and fished it out. And even then, the child had a nasal septal perforation. But if you'd left it in until the next day, it would have been disastrous. So that's a real public health message about button batteries. Most of the time, it's little bits of toys or food. And the main thing with foreign bodies in the nose is that you get one good shot. So it's better to refer to ENT, who have got the right tools, and you really get one good shot. And the key message is to get your hook behind the foreign body and drag it down. If you try and get it out with forceps, it tends to slip further in, and then you need to resort to a general anesthetic. And if you don't get it out, then you might need a general anesthetic to get it out. Same with ears, you get one good shot. And so, you know, the main aim is to do no harm. You know, so don't worry if you're working in A&E or GP and you see a foreign body in the ear, don't worry about referring to ENT without even trying, because once you've had one go, the child won't let you anywhere near, and it will need a general anesthetic. Here he is. Right, foreign bodies in throats. So children have a knack of swallowing coins as well as other things. So the approach to foreign body in throat is using a combination of history, examination, and selected investigations to establish your index of suspicion. So you might have a very worrying history of someone having definitely ingested a chicken bone or a sharp lamb bone. And the examination isn't really that obvious, and it may not show up on X-ray. You might have it that the history was fairly innocuous, but the X-ray shows up something. So you want to use all those three things, and lateral soft tissue neck X-rays as well as chest X-rays can be very helpful. Okay, not all fish bones show up on X-ray, so a normal X-ray doesn't necessarily mean that everything is okay. If someone ingests a food bolus that gets stuck in the esophagus and there's definitely no bone, then you can manage it conservatively for a time by giving buscopan and getting them to relax and see if it passes. But if it doesn't pass, or there's anything sharp in the food bolus, or in children, anything like coins or batteries, they all need to come out under general anesthetic. So there's just a reminder that not all fish bones show up on X-ray. The way I remember it is that if it's your classic chip shop punter that's had cod or haddock, then those bones do show up on X-ray. But if you're working in a particularly posh location and someone's had a posh breakfast fish like herring or kipper, they don't show up, so don't get caught out. So in summary, a soft foreign body can be managed conservatively. Anything sharp or batteries need to come out straight away. And this is just to show that X-rays can be difficult to interpret. So all this here is normal laryngeal cartilage, and the foreign body on here is probably somewhere here in the esophagus. So it can be tricky. Okay, moving on to ear problems. So here's a reminder of ear anatomy, which is my subspecialist area. You've got your ear canal, tympanic membrane, malleus, incus, and stapes, connecting to the oval window of the cochlea, and then the vestibular cochlear nerve going away from it. So the most common emergency you might see with regards to ear disease is otitis externa, very commonly seen in GP, patient complaining of pain, discharge, and hearing loss. And this is often caused by Pseudomonas and staph in the ear canal. An infected ear canal will produce debris, and the best way to treat it is with drops. So often see people giving oral antibiotics for this, but that really is ineffective. You need to give drops, and preferably a drop that contains antibiotic and steroid. So Gentazone HC and Sofradex are probably the two most effective ones. But if the ear canal has produced so much debris that the drops don't get in properly, that's where you need to use microsuction. And that's where the ENT emergency clinic is useful, where you can clean the ear and then start using the drops after that. So this is one of the very practical skills that you'll do as an ENT SHO. Now, sometimes the ear canal becomes so inflamed that it's stenosed and the drops don't get in. And here a Pope wick is really useful. So Pope wick is basically a tampon for the ear canal, slide it into the ear canal and put the drops on so that the drops get to where they need to get to, and then revisit in 2 or 3 days and you can pull the Pope wick out and usually the ear canal has opened up a little bit again. One thing you do need to be aware of is something called necrotizing otitis externa, otherwise known as malignant otitis externa. And this is a skull-base osteomyelitis, and untreated, it can kill you because essentially the bone of the temporal bone becomes infected, and the infection tracks medially towards the brainstem and cranial nerves. So you need to think about it in a patient that's got non-resolving otitis externa, night pain, and is immunocompromised. So you want to be thinking about it in people that have got diabetes or are on chemoradiotherapy. And as I say, night pain, granulations in the ear canal, and otitis externa that isn't resolving are all clues. And so you need to get a CT scan to confirm the diagnosis. And once the diagnosis is confirmed, then involve infectious diseases and start the patient on a long-term course of IV antibiotics. So usually they will get a long line and usually go home with a line and have antibiotics at home for an extended period of time, minimum of 6 weeks, if not longer. And obviously control their sugars and involve other specialties as needed if the cranial nerves are affected. So otitis media, this is a condition that's really common, and it's classically in a child that comes tugging their ear, fever, crying. If they're a little bit older, they'll be able to tell you that they've got a sore ear. And this is this otitis media is essentially inflammation of the middle ear space, so the space behind the eardrum. You look in the ear, the eardrum will be bulging. Now, most of the time, this is viral, so you just need to give painkillers and ride it out. It's not required to give antibiotics to every case, but there are circumstances where you should give antibiotics because untreated, bacterial otitis media can progress to complications, which I'll go on to. So any child under 2 needs to have antibiotics. Any child with bilateral ear pain needs antibiotics. Any local complications such as facial weakness, dizziness, visual change and neck swelling, or if it's not getting better after 3 days. So you might see GPs give a delayed prescription for antibiotics in this case. What you don't want to see is this, which is acute mastoiditis, where the ear is pushed out, there's swelling behind the ear, and it's starting to become red and tense. And this is a complication of otitis media. Obviously, that child needs admission. They're going to need urgent intravenous antibiotics. And by the time it gets to this stage, they're almost certainly going to need an operation to incise and drain that pus and probably drill away some of the cortex of the temporal bone. It's important to get a CT scan before you do that, because what you want to do is check that there's no intracranial spread, because the last thing I want to be doing is taking a child to theatre to drain a mastoid abscess when they've also got a brain abscess, and I need to have involved neurosurgery as well. Okay, moving on to hearing tests. Have a look at this audiogram of a young adult and try and figure out what's the most accurate way of describing it. Put the answer in the comments, no judgment. Don't expect anyone to know the answer, but good if you do. I'll give you a minute to do that. Okay, so the correct answer here is left-sided conductive hearing loss. Let me explain why. So going back to the anatomy of the ear, you can tell from an audiogram whether a hearing loss is conductive or sensory neural. And a conductive hearing loss is caused by a problem somewhere between the entrance to the ear canal and the stapes. So blockage of the ear canal can cause it, a hole in the eardrum can cause it, stiffening of the ossicles can cause it, chronic disease in this area can cause it, conductive hearing loss. And that manifests as a gap between the air and the bone on the audiogram. So here we've got an air bone gap, a gap between the air and the bone, suggesting that it's a conductive hearing loss. And by interpreting the audiogram, you can sort of infer where the problem is when a patient comes with hearing loss. Sensory neural hearing loss is caused by problems with the inner ear or brain, and sometimes you get a mixture of both. And the reason it's important to be able to differentiate between that is because sudden hearing loss that is sensory neural in origin is a medical emergency. And it's amazing how this is still a public health message that needs to get out there. Not everyone is aware of this. Sudden sensory neural hearing loss should be treated as an emergency. So if a patient says they've lost their hearing suddenly, what you need to do is use tuning forks, Rinne and Weber testing, to differentiate whether that hearing loss is conductive or sensorineural. And in a sensorineural loss, the tuning fork on the forehead will lateralize to the other ear, whereas if it's conductive, it will lateralize to that ear. So that's really important. And if it's sudden and sensorineural, then they need to be referred to ENT urgently and steroids started. And we might consider an intratympanic steroid injection, so an injection of steroids through the eardrum as a way of bathing the inner ear in steroid to try and recover that hearing. Okay, what's going on here? So this guy obviously has a broken nose. You can see that his nose is deviated to his left. Probably the most famous broken nose in the world, because when you Google broken nose, this guy's face comes up. I sometimes wonder whether he knew that when he had this picture taken. Nevertheless, imaging isn't helpful to diagnose a broken nose. You can just look at it and know that it's broken. And so there's no need for x-rays. What you do need to do is make sure there's no septal hematoma. So you need to look in the nostrils and make sure there's no boggy swelling. If there is, then that needs to be incised and drained to stop the cartilage from being from necrosing and causing a nasal collapse. And one thing that can be done is that this nose can be manipulated back into the center in a certain time window. So it's usually too swollen to do it right at the time of the injury. And if you wait more than 2 or 3 weeks, often the bones have reset and it's too late. So this patient needs to be seen by ENT in the days after the injury, and a manipulation planned for between day 7 and day 14 to basically crunch the nose back into the midline. We usually use a short general anesthetic, although it can be done under local. So that's the key thing there. Don't miss the time window if you're seeing patients like this. A septal hematoma looks like this. It's a boggy swelling that you see through both nostrils. That needs to be referred urgently for drainage in theatre. Okay, so I always thought it's amazing at med school how you get taught how to test vibration sense in the toe, but how often do you get asked to look in a throat and diagnose something as simple as tonsillitis? Yet it is so common, and any of you that will work in A&E and GP will see loads of this. So this is tonsillitis. Essentially, if they can't swallow, they can't eat and drink, that's the criteria to admit the patient. So if they're not getting enough oral intake, admit them and treat them with IV fluids, intravenous antibiotics, which is usually benzyl pen and metronidazole. Don't give anything containing amoxicillin because it can give cause a rash if the patient has glandular fever. And then painkillers, and we usually give some steroid in adults as well. And then once they're eating and drinking, you can convert it to oral antibiotics. Then you also want to get a monospot to make sure that it's not glandular fever, which is really common in the student population. It's treated the same way. The only difference is that once you've made the diagnosis of glandular fever, you need to warn the patient to avoid contact sports for 3 months because of the risk of splenic rupture from hepatosplenomegaly. And often you see, it's usually in young adults, and you see this kind of white coating over the tonsils. That's the sort of giveaway that this is glandular fever. Okay, so you want to be paying attention to where the uvula is, that dingly dangly thing at the back of your throat, as you might hear in the songs at the moment. So when people often wonder, has this patient got a quinsy? A quinsy is a peritonsillar abscess, and the clue is in the position of the uvula. The uvula should be central in a severe tonsillitis. Once it's deviated, then you want to think about a peritonsillar abscess. That means that there's pus in the space between the tonsil and the pharyngeal muscles. And once you diagnose this, it needs to be drained. And the way to do this is with a good headlight and a tongue depressor and a needle. As horrible as that sounds, it is a really good thing to do, and the patient gets instant relief. So you put the needle into the bulge and aspirate, and if you do get pus, then you can use a knife to incise that space and let it drain. And that really should be done. You shouldn't wait till the next morning to do that, because patients can suffer from from problems with opening the mouth and airway obstruction. So the way to do it is to spray the throat and essentially just go straight. So don't deviate too far laterally. The carotid artery is, after all, 2 centimeters away, but you'd have to try pretty hard to hit that. And yeah, essentially make a vertical cut in the place that you've aspirated so that it doesn't recollect. Okay, so tonsillectomy is an operation that ENT do a lot. We do it for patients that have recurrent tonsillitis and also for children as well as adults that have problems with obstructive sleep apnea. Now, the trouble is that however well that operation is done, there is a proportion of cases who will have a bleed in the first 2 weeks, what we call a secondary hemorrhage. And that rate is quoted anywhere between 1 and 10% actually. So we always warn patients, if you have any bleeding, you need to get straight back to A&E because you might need to go back to the theatre. Now, if you're ever working in A&E and you see a patient that has had some bleeding after a tonsillectomy and it's stopped, you should always admit them because a small bleed can signify a larger bleed along the way. So always admit them for a period of observation, even if the bleeding has stopped. Always involve ENT reg on call. If the bleeding is ongoing, they basically need to go back to theatre. You can give them hydrogen peroxide gargles in the meantime. And obviously the usual ABC rules apply. So fluid resuscitate, make sure they're grouped and saved, clear the airway. And yeah, if the bleeding stops, then observe for 24 hours. And if the bleeding's continuous, then we take them to theatre and we use bipolar diathermy to stop the bleeding. Okay, finally, the ENT emergency that everyone worries about is stridor, airway obstruction. So what is stridor? Stridor is a high-pitched noise that signifies airway obstruction. So it's a kind of a very sharp noise, which you should differentiate from stertor, which is that sort of gurgly, snory noise that you hear when you sit on an aeroplane and someone falls asleep next to you. So now stridor means that the airway is at risk. So when you hear stridor and you recognize that the airway is at risk, then you want to protect that airway before you worry about what exactly is causing it. And basically you can do some simple things until help arrives, such as airway maneuvers, jaw thrust, head extension, giving oxygen, steroids, adrenaline. If it's appropriate to have a look in with a flexible nase endoscope into the nose and into the throat, then do that. But otherwise, you want to involve anesthetics and ENT early, and the decision needs to be made as to how to clear that airway obstruction. It might be that the patient needs to be intubated. It might be that that patient needs a surgical airway. And there are different causes for airway obstruction in children compared to adults. And I'm going to put them on the screen here. So in children, you want to be thinking about foreign bodies and infections. In adults that come with very severe airway obstruction, it's usually because of bilateral vocal cord palsy or head and neck cancer. So there are a few reasons that you might need to do a surgical airway. One is for upper airway obstruction, either at the level above the vocal cords or at the vocal cords. Or if you're expecting airway obstruction, so for instance, someone that's about to have chemoradiotherapy for their head and neck cancer. You might also do it for someone that's going to have long-term suctioning. And obviously at the moment, we're doing quite a few trachees for patients who have been intubated with COVID and are not quite progressing. And in order to take their ventilatory tube out, you need to put the oxygen in another way, and that's through the neck. So that's another common reason to do a tracheostomy. And that's how it's done. So that's, it's beyond the scope to sort of explain how to do it, but just to say that that's something we do a lot in ENT and is a big part of being emergency safe as an ENT surgeon. Good. So I thought it might be worth saying a little bit about ENT. You don't get much exposure to ENT at medical school, and so lots of people don't discover it until very late. And because of that, a lot of people think it's kind of niche and pooky with basically just dealing with snot and wax. But I would say it's one of medicine's very well hidden careers. The reasons I like it are the patients are young and old, so I look after newborn babies who are born deaf, right up to young adults and older adults with hearing problems. ENT means there's a wide variety of cases, and every day is different as a trainee. And as you can see from this talk, it's very high impact medicine. So it's very practical. Patient comes in with a problem, you do something hands-on to make them better. So it's very practical, very high return medicine. Obviously, technology and gadgets is a big part of ENT, which is, if that's of interest to you. The surgery is very delicate, so I have to keep my hand really still in my ear surgery. But that, with challenge comes reward, and certainly the end result, the emotional impact of what you do, is huge. And I think I know a lot of you students. What I'd say is, when you're choosing your career, look at the consultants, because that is what you'll end up doing for 30 odd years. And I would say that ENT is full of generally collegiate people that are easy to get along with, and that tends to attract more people like that. And there's a fairly favorable balance of men and women. I think there's always room for improvement in surgery, but in terms of surgical specialties, we're probably one of the best in that regard. So I run an Instagram channel with lots of sort of ENT bits and bobs and insights into surgical life. So do check that out if that's of interest to you. Good. For those of you on the training pathway, I've written these 2 textbooks, which quite well used amongst ENT trainees in the UK. The one on the left is for med students and junior doctors, and then the one on the right is for more senior trainees. Good. I'll stop there. Happy to answer any questions.
Thanks so much. Yeah, guys, if you have any questions, feel free to just drop them in the chat. About ENT in general, in a wider sense, or anything about the lecture today.
So a question about glandular fever and why we give antibiotics. That's a good question. So we can't easily rule out a superadded infection over virally swollen tonsils. So that's why we generally cover with antibiotics as well as steroids. So I hope that will have encouraged some of you to think about ENT as a specialty. Yeah, if you want to message me with any career-related questions, I'm happy to answer them. You might hear my little one in the background getting restless.
We've got a question here. What is the most common ENT emergency?
The most common ENT emergency, probably toss up between acute tonsillitis and epistaxis, with foreign bodies probably being number 3, I would imagine.
Perfect. Okay, we're going to just share the link in a second, just having a bit of problem sharing the link. But for those of you who are here today, if you guys can please just fill the feedback form in, and we'll send you a certificate upon completion.
Great. And I've had a question about what are the causes of sudden sensorineural hearing loss. So there are loads, but you want to think about it in terms of a surgical sieve, so infective, autoimmune, neoplastic. So we'd usually get an MRI scan to rule out a benign tumor of the hearing and balance nerve, but usually it's of unknown etiology, and we presume that it's a virus that's caused it.
Fantastic. So yeah, guys, we've got the feedback form in the comments in the chat section, so please fill that in. And I'd like to thank Mr. Manjaly for giving up some time in your evening. Thank you so much for joining us on behalf of the entire committee here today. Yeah, and I hope you guys all enjoyed it. Like I said again.
Sorry, there's just been one more question, if that's okay. Sonia's asked, she said, great talk. Could you please ask Dr. Manjaly the training pathway he undertook for his current position? Thanks. Yeah,
so I did foundation training in Bristol for 2 years. I didn't do an ENT job in that time. There was an anatomy demonstrating job I was keen to do. And so my first ENT job was in core surgical training. So I did 2 years of core surgical training, of which 16 months was ENT. So ideally you want to apply for core surgical training with an ENT theme. During which time you try and pass your MRCS ENT. And then you apply for ENT registrar training, which is through national selection. So that's actually happening today for the current cohort. But it's a national interview where all the trainees in the country apply, and you're ranked from 1 down to number 32, however many jobs there are in the country. And the top person gets their top choice job, etc., etc. And then it's a 6-year program where you rotate through different subspecialties. And at the end, you can apply for a consultant job. If there's some suggestion that you're being sort of lined up for a kind of tertiary job, then you'd go and do a fellowship. So I went to Cambridge to do a fellowship in otology and auditory implants. Yeah, that was great preparation for my job that I'm doing now. So it was 11 years of training in total after graduating.